It's a little more common as people get older, but it can really occur almost at say any age. From in very rare occasions, people in their 20s and then up until people in their 80s and 90s can get diagnosed with Parkinson's disease. And it's a disease process where, in kind of simplified forms, your brain is not making enough dopamine because a small part of the brain has started to die out, called the substantia nigra, and its job is to make dopamine. And so the brain of someone with Parkinson's disease doesn't make enough dopamine. And that's kind of one of the main features that we see. And pharmacologically, that's where we do a lot of the focus of our treatment. And so when you're not making enough dopamine, we try to give your brain, say, a precursor so it can make dopamine more easily. And that's what carbidopa levodopa is. And that's kind of the main Parkinson's medication, although there's many others. But carbidopa levodopa, and particularly levodopa, is the drug that when your brain takes it, it can turn that into dopamine. The carbidopa part of that drug is what we use to help the levodopa get to your brain without breaking down in your bloodstream. And so recently there's been a couple new versions of carbidopa levodopa. Carbidopa levodopa has been out for a while, quite some time, and it's still been the main medication to treat Parkinson's disease. There's new forms of it. They've made different types of longer acting or different formulations of carbidopa levodopa, but it's still all basically the same drug, that just the metabolism of it or in your body can change a little bit with how they formulate it. So there's a new drug on the market that's a new type of extended release carbidopa levodopa, but it's still carbidopa levodopa. And then so that I had a few patients ask me about that more recently, because that drug just got FDA approval, and it's still just, once again, carbidopa levodopa. They've made carbidopa levodopa where you can break it up a little bit easier. So it's carbidopa levodopa, but the pill is formulated to snap in half a little bit easier than the other small yellow round ones that don't really break in half very well. That's just and once again, that's still carbidopa levodopa. And they have a capsule form of carbidopa levodopa called Vitari. And that one is one that's still same drug, but it's just in a capsule, and it has a little bit of a short-acting and long-acting component together with it. And then there's a traditional long-acting form of the medication just called, carbidopa levodopa long-acting, and it's one that I'm sure I prescribe it a lot for people to take at night before they go to bed. It seems to help them, particularly with experiencing off times in the morning. So that's kind of the main medication to treat Parkinson's. There's another group of drugs out there called dopamine agonists, which are fairly common to treat Parkinson's, particularly in people who tend to be a little bit younger. These are drugs like Mirapex or Requip, or one called Nupro. And it is a drug that's made to look like dopamine to your brain. So you take it and it goes to your brain. It kind of functions as if it's a synthetic form of dopamine, or stimulates dopamine receptors in your brain. And these drugs work well to treat the symptoms of Parkinson's disease. They have some more side effects in general than carbidopa levodopa that get more pronounced as people get older. So we tend to use the dopamine agonist, like I said, in a little bit of a younger population. They cause people to feel more sedation or tired when they take them. So drowsiness. They can cause this thing called sleep attacks, where people are awake and then they're at a stoplight and then they're asleep, so they fall asleep pretty quick. So it's something we watch out for with those drugs. And then they also can cause some obsessive compulsive behavior in some people. This, where if you were to check your email 5 times a day, maybe you check your email 50 times a day now when you take the medication. Or you're on the internet all the time, compulsively shopping or buying things. And so that's something we watch out for with those medications. But in a certain sort of the population, they work well. They're a little bit better at treating tremor than carbidopa levodopa is. And then we have a group of drugs called the anticholinergic medications. And these are drugs that are a little bit better for tremor. The main one that we use is a drug called Artane, or trihexyphenidyl. And I use it also in younger people, but for help with tremor. But the older you get, that can cause more dry mouth, urinary retention, and hallucinations. So we always watch out for the side effects of the medications when we're using them in people. There's drugs that are designed to make the dopamine last longer. So after you make the dopamine, we want the dopamine to last as long as possible because you're not making enough. And these are drugs like MAO-B inhibitors, which is the common one we use is a drug called Azilect, or rasagiline. There's one called selegiline. These are out there. They have little caveats to their usage. And then there's drugs called COMT inhibitors, which have been around for a long time, but there's a new one out on the market that's once a day called Ongentys. But they work and they help prevent the dopamine and once it's made from being broken down. And so these are drugs that we use to kind of extend the life of the carbidopa, levodopa, and more appropriately extend the life of the dopamine that your brain is making. And that's the main focus there from a pharmacologic standpoint. And there's talk and I think in the press a lot about other things. There's interventions that we can do from a surgical standpoint. So the surgical treatment of Parkinson's or tremor is a big topic to talk about too. One is with deep brain stimulator surgery, which has been around for a while now. I think since the late 90s, and it's been used to help reduce tremor and help augment the treatment of Parkinson's disease by helping reduce things like dyskinesia and motor fluctuations. So when I say words like dyskinesia and motor fluctuations, does everyone know what I'm talking about? No, that's great. Good. So good. So and feel free to ask if I'm saying, "Hey, helps dyskinesia," and you say, "What are you talking about?" You can just say, "Hey, what do you mean by that?" And I'll be happy to answer that. Dyskinesia are extra involuntary movements that happen in people, typically associated with the use of Parkinson's medications. And probably the most common example would be when people say someone like Michael J. Fox, and I use him as an example because sometimes when he's on the news or in the public press, he'll have extra movements. He won't be able to. He doesn't really sit still. Kind of moves a lot extra. That's what dyskinesia is. It's these extra movements. And now that's not really from the Parkinson's disease specifically. It's from the medications that we use to treat the Parkinson's disease, and that gives people those extra movements. The extra movements are usually preferable to moving less, or what we call bradykinesia, or being frozen and not being able to move at all. When sometimes we say about 50% of people after about 5 years of carbidopa levodopa therapy will develop some dyskinesia. It's a little more common in younger patients, but we see it at any age. And so using different therapies like deep brain stimulator surgery can sometimes help minimize dyskinesia in people. Also, certain drugs like amantadine can be used to help minimize or reduce dyskinesia in people. And then there's a thing called motor fluctuations, which I was just talking about. And a motor fluctuation is when people take their carbidopa levodopa, and it helps to treat their symptoms. They feel better, they move faster, they're less slow, they're less frozen, or they can move quickly. Then it wears off, and they only get maybe 2 hours or an hour and a half of benefit from taking the medication, so they have to take the medication again. And then they have to take the medication 5, 6, 7 times a day. And so that's what a motor fluctuation is. And stuff like deep brain stimulator surgery can really help reduce the motor fluctuations in people. And when I mentioned the new drugs on the market are kind of these new forms of carbidopa levodopa, they're really kind of designed to try to treat people all day long or help reduce that roller coaster that people get on when they've been on carbidopa levodopa for a longer period of time. And so that's one of the struggles that we're trying to treat with Parkinson's disease, is trying to help deliver medication in a continuous fashion. And so they've actually gone so far as to have a way that we can infuse carbidopa levodopa into the GI tract directly, and that can help reduce motor fluctuations. We can give people a pump of a dopamine agonist and called apomorphine, and it goes into just under the skin, sub-Q, and it can help treat the motor fluctuations as well. And then they're working on ways to directly give people carbidopa levodopa sub-Q as well too. So these are things that are all kind of being worked on to help minimize motor fluctuations. Yes. Uh-huh. Okay. Perfect. Yeah. So the surgery I was referring to is the deep brain stimulator surgery that helps reduce the motor fluctuations in people. So once we put an electrode into the correct part of the brain and we provide some stimulation, it provides a baseline kind of anti-Parkinson's effect. So it treats the Parkinson's disease all the time because the DBS is always on. And so it would give you a baseline treatment. And with that, and with some of the reduction in medication that you can expect with a DBS surgery, that can help reduce dyskinesia. There's another, we could also do the surgery in another part of the brain that has more of a direct anti-dyskinetic effect. And so if someone has a lot of dyskinesia, we can do the deep brain stimulator surgery. And we'd focus on a part of the brain called the globus pallidus internus. And that's just another part of the brain that helps reduce Parkinson's symptoms, but also helps reduce dyskinesia. So does that help clarify that? Great question. Yeah. The other surgery I was talking about is to administer the medication through the GI system it's like a tube that's placed into your intestines directly, and that helps infuse the medication. Yeah.
Are there any nutritional, natural, organic components?
Yeah, so from a natural standpoint, or non-pharmacologic standpoint, or from a drug that's made, not made by some sort of company, I guess, there's not a lot that's available. There's a form of levodopa called mucuna, or dopamine is what it's sold under mostly. It's sold in health food stores, and so it's a bean. I think it comes from India. I'm not sure. It's grown in a few places in tropical environments, and it has a little bit of levodopa in it, or some levodopa in it. And so you can take that, and that can help with some of the symptoms. It works better if you take that with carbidopa, the drug that's part of carbidopa levodopa. And if you took carbidopa with mucuna, that tends to work a little bit better for people. But that's the only thing I could think of that's kind of like a supplement that I would say I would recommend for Parkinson's disease. There's a lot of other things, though, that are very beneficial for Parkinson's disease that are not medications. Namely, exercise and physical activity is extremely important for Parkinson's disease, and really keeping people mobile. So doing things like rock steady boxing, or even any exercise you want to do, is something that's really helpful. Working with physical therapy is extremely important to give you guidance on what exercise are going to keep you mobile and keep yourself moving. So those things are very important to do. And physical therapy and occupational therapy and speech therapy, they're all prescription drugs, but they are therapies that really help people out to keep people mobile and keep people doing the best that they can. And so if you get a diagnosis of Parkinson's disease and you have a more sedentary lifestyle, you don't do a lot of stuff, that can sometimes lead to, we see the disease progress faster in people. And so the healthier someone is and the more active they are, the better they do with the disease process. Does that answer some of your questions? Yes, great. Yeah, you had a question? Yeah. 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 Right. So it's a little bit of all the above. I think that's a great question. And I don't have a specific answer for why people get Parkinson's disease. Certainly there's a genetic component to the disease process. So certainly there are genes, and a number of these genes have been identified that put people at higher risk for Parkinson's disease. These genes are not what we call 100% penetrant, which means that you can have the gene, though, and never get Parkinson's disease. So having a gene for Parkinson's doesn't mean you're going to get it. It means that you have a higher risk of getting it. So there is a genetic component. So if you have a first-degree relative, that has Parkinson's disease, you have a higher risk of getting Parkinson's disease yourself. So if your mom or dad or brother had Parkinson's disease, you have a little bit of a higher risk of getting it. It's not a drastically higher risk. It doesn't mean for sure you're going to get it, but it does mean you have an increased risk of getting the disease process. We know that there's certain environmental factors that take place that are associated with Parkinson's disease. And these are really interesting studies, but it's important to recognize that there is a difference between what we call causation and association. So when something causes a disease process, we know for sure that whatever it is going to cause the disease. Other things are kind of just more associated with the disease process. We don't know how, we're not specifically sure how they cause the disease to become more likely. So if you live in a more rural environment, you have a little bit of increased risk of Parkinson's disease. If you drink well water, there's an increased risk of Parkinson's disease. Small amounts, though. These are not really super strong association. More exposure to pesticides, herbicides have been associated with an increased risk of Parkinson's disease. So we know these things are kind of true, but we don't know exactly how or what amount or when the exposure takes place, how it's associated with getting the disease process. So it's a great question, but not one that I have clear answers for. Um, so, yeah. You mentioned injury, physical injury. So physical injury too, I think a lot of people associate things like multiple head trauma with Parkinson's disease, or boxing with an increased risk of Parkinson's disease. That's probably it's probably not necessarily sort of directly what we call idiopathic Parkinson's disease or kind of regular Parkinson's disease. There's Parkinsonism or Parkinson's-like diseases that you can get, and some of those are associated probably with more head trauma than, say, pure Parkinson's disease. So to kind of clarify what I mean by that, sometimes you'll hear neurologists use the word Parkinsonism as opposed to Parkinson's disease. And so when I talk about Parkinson's disease, I'm really referring to kind of typical, we call idiopathic Parkinson's disease. We don't think it's caused by anything else, but just what we typically see with Parkinson's. There's these groups of disorders called Parkinson's plus conditions, which tend to look like Parkinson's initially, but then as time goes on, they distinguish themselves from being just like a typical Parkinson's disease, and they have extra features. So there's a disease, for example, called PSP, or progressive supranuclear palsy, and that disease looks like Parkinson's initially, but it tends to be a little bit more symmetric, and regular Parkinson's tends to be more asymmetric. It tends to have a lot more difficulty with gait and balance and falls early in the disease process. People have a difficult time looking up, and there's some eye movement abnormalities that are associated with the disease. And they have much more axial rigidity. So they're much more stiff in their torso than someone typically is with what we call regular or typical idiopathic Parkinson's disease. And you don't have to, worry about the name PSP specifically or anything like that, but it's just to recognize that not everything that looks like Parkinson's always turns out to be Parkinson's. There's also a vascular Parkinsonism that occurs in people, where people have had a lot of what we call vascular changes to their brain. So they've, maybe they've had a lot of high blood pressure, high cholesterol, cigarette smoking, stuff like that. These exposures that we know cause vascular changes to the brain, an accumulation of those can give people some Parkinson's features. And the key to all these kind of Parkinson's plus or Parkinson's related disorders is that they tend not to respond as well to medications as regular Parkinson's disease does. So when I have someone I'm seeing in clinic and they don't respond well to Parkinson's disease medications and they have these extra features, we start to wonder about if they have a Parkinson's plus condition as opposed to regular Parkinson's disease. A very common one that we hear a lot about too is Lewy body dementia, which is a form of Parkinsonism. And Lewy body dementia is a form of dementia, so it's a form of a cognitive decline, but the person also has some Parkinson's features to it. And just recently, there's been some good data, and we can now order a skin biopsy in people to look at the diagnosis of Lewy body dementia. And so that's a newer thing that we have in our clinic. Yeah. Mhm. Yeah. Mhm. Yeah, that's a great question. So I'll repeat it. So the question is why does this particular part of the brain die out, and is there something special about that part of the brain that makes it susceptible to dying out? Would that be what you're asking? Yeah. So if we really knew the true answer to that, it would be a huge scientific breakthrough. We don't know exactly why. We know that the neurons in the part of the brain that die out, the substantia nigra, we know that they are smaller neurons that are what we call unmyelinated, so not as protected as other neurons in the brain. So they may be more susceptible to different stressors than other parts of the brain are. There's also these hypotheses where we kind of see the disease process of Parkinson's disease spread throughout other parts of the nervous system. And so we know that sometimes the pathology of Parkinson's disease kind of spreads actually through the olfactory nerve, the nerve that we use to smell, and kind of spreads that way up into the brain. And there's also some sort of spread or travel of disease pathology through the GI system. And that's an area of active research to see if the disease is somehow starting there and spreading up to the brain, or where it really starts from. And it's a very interesting hypothesis that people have been looking at for a large number of years. It was about how the disease spreads. Is there some sort of contact in the environment that causes, this pathology to occur through the nose or through the GI system that spreads up to the brain? And how long does this take place in a person? So let's say if I was going to get Parkinson's disease at 60, do I have signs of that in my GI system or my nerves when I'm 40? And so they're trying to do clinical trials looking at that, trying to figure out, could you look at someone who is 40, do some sort of test on them via that same principle we're talking about, and say, okay, you're going to get Parkinson's disease in 20 years or 30 years or 10 years, and then do something about it. The big push would be, right now, if I were to take a 40-year-old and do a test on them to say, okay, it looks like there's a 70% chance when you're whatever age that you're going to get Parkinson's disease, that information is not really helpful to them, and actually could be fairly damaging to somebody if you knew that there was not a definite, thing that would happen, but a possibility that you could get a disease process later in life. And you can't do anything about it, except for live healthy and exercise and eat right, which you should do that anyways. That's where that kind of falls short a little bit, until there's an intervention that we have to offer somebody to change that trajectory. And so okay.
I had
Uh-huh.
and I did Botox treatment for that from Hartford, and I know that that's neurological.
Mhm.
And my brother has Parkinson's.
Yeah.
So on it.
As far as we know of right now, we don't think that they're related in the sense that having spasmodic dysphonia is going to be related to having Parkinson's disease. Spasmodic dysphonia is in the group of disorders called dystonia, and dystonia occurs in people with Parkinson's can have dystonia, but it's a different disease process for what we call pure dystonias or isolated dystonias. And so we don't think that they're necessarily associated with a risk for Parkinson's. Now, if we did a population trial, we would probably find out that people with dystonia may be more likely to get a diagnosis of something like Parkinson's in their life, but that also may mean they're more likely to encounter a neurologist, which would increase your risk of getting a diagnosis of Parkinson's too. So we don't think that there's necessarily a direct relationship. So, yeah, great question. Yeah.
What chemistry goes up in everybody that
No, and that's a great question. So the question is another great question. Is there a blood test you could do, or is there something that shows up in the blood that would say, okay, yeah, you have Parkinson's disease? So that's an area of active research for these neurodegenerative diseases, to have a way that you could do a blood test and say, oh, your blood test is consistent with Parkinson's disease or Alzheimer's disease or a different type of dementia or PSP or something like that. Is there a biomarker, is what they're called? Is there a biomarker that we could use in people to give them the diagnosis of these disease processes? And there's right now there's not one in the blood that's reliable to use. They're really trying to find one though. For something like Alzheimer's disease, there's not one in the blood that is FDA approved to give someone the diagnosis of Alzheimer's disease. But you can do a spinal tap in people to look further at some of this stuff. But even then, that's not 100%. But we do use that for Alzheimer's disease now. We do use spinal taps to look for markers of, say, something like Alzheimer's disease. But not yet as much for Parkinson's disease. You can do a skin biopsy in people to look for a distribution of a protein called alpha-synuclein, and that's associated with Parkinsonism or some Parkinson's diseases, but it's not would be specific for regular Parkinson's. It would be specific for a couple of diseases, including Parkinson's and Parkinson's-like disorders. Yeah, great question. But I can foresee in the future there might be a blood test which we could use to help confirm the diagnosis. So that leads us to another question that I think some people would want to know is, how do we diagnose Parkinson's disease? And so when you see your doctor and they say, I think you have Parkinson's, and they send you to see a neurologist, how are they going to diagnose you with Parkinson's disease? And the mainstay, the key thing that is still very important at diagnosing Parkinson's disease is the physical exam. So when you come to see a doctor, they look at you, they have you do certain things in the exam room. They have you tap your fingers, they have you tap your feet, they watch you walk, they see how you swing your arm, they see if you walk stooped over, they see if you shuffle your gait, they see if you have a decreased blink rate, all this type of stuff. They do a lot of tests on you in the exam room, and that's supposed to help us look to see if you have Parkinsonism. If there's still confusion about whether you have Parkinson's disease or not, we could do this thing called a DAT scan. It's a dopamine transporter scan, and it's a scan that'll see if you have dopamine deficiency in your brain. And so that's something we do for some patients if we're not sure if they have Parkinson's disease or not. The DAT scan would be positive for Parkinson's disease, but it would also be positive for other neurologic disorders that look like Parkinson's. So people with PSP or other related Parkinson's disorders would also have a positive DAT scan too. There might be some caveats to say, well, the DAT scans can look a little different, but it's still an area to where there'd be some confusion. So if someone had a DAT scan that was abnormal, I'd be more thinking that they likely had Parkinson's disease, but they could also have one of these other conditions too. So, but really it's the physical exam. And then also when you see somebody more than once, you want to see if they're progressing like someone with Parkinson's disease would progress. So you want to make sure their progression is typical. You also want to make sure that they're responding appropriately to the medications that we use. So if we try carbidopa levodopa and it does absolutely nothing, and we try a higher dose and we try a higher dose and it still does absolutely nothing, then we have to wonder, is this really regular Parkinson's disease, or is it something else that looks like it but is a little different? Okay. And does it matter to distinguish whether they have Parkinson's disease or something like PSP? Is the treatment different? Well, the progression of the disease is different. The typical response to medications would be different. And the prognosis can be different too. And what we'd expect to see in someone in the future would be different. So that's why we want to differentiate between these diseases. So, yeah. Yeah, so the treatments are the same. So the question is can we talk about different kind of types of Parkinson's disease? And some doctors would refer to this as like different flavors of Parkinson's disease. So it's all Parkinson's disease, but there can be different looks to Parkinson's disease. And I always tell everyone that we see in clinic that everyone is different. And so everyone's Parkinson's disease is going to be different. And your therapy that we use to treat your Parkinson's disease medication-wise is going to be tailored to you. So if you got a bunch of people together and you talked about what medications that you use, it's all going to be different. And that's because you should be getting a treatment that's not from like a cookbook or anything like that. It's all directed based on what symptoms you're having and what we're trying to improve. So there's the tremor dominant Parkinson's disease. And I think these people tend to get diagnosed earlier in the disease process, because if you go to see your primary care doctor and your hand is shaking like this, and which is a typical Parkinsonian tremor, they're going to notice it. And they're going to say, hey, your hand is shaking. How long has it been doing that? Maybe we'll send you to see a neurologist. But if you have a more rigid predominant form of Parkinson's disease, where you don't have much tremor, but you just start to move a little bit slower and start to talk a little bit softer and walk a little bit slower, and you have more of a masked face, which will occur in the other form of Parkinson's too with the tremor, but it's with the more rigid form of Parkinson's disease, these are harder for people to pick up on, and they don't obviously, scream this is Parkinson's disease from the beginning, particularly from when you're just seeing your regular doc. They're harder to describe the symptoms. If you see a regular doc and you say, well, I feel really slow, They'll say, well, are you tired? Are you not sleeping well? All these other things. Are you anemic? Did you have a thyroid problem? Are you low on B12? There's all these other things that can cause people to feel slow that they'll probably can look into before they jump to Parkinson's disease. And so I think it'd be a hard study to do, but I think from anecdotal experience, if you're more of a rigid predominant person, you're going to probably have the disease longer before we recognize that it's Parkinson's disease than say if you have a nice kind of classic resting tremor, because it's just so easy to see and you can't ignore it. And your kids are going to say, hey, Mom, what's wrong with your tremor? Or Dad, why is your hand shaking? That type of stuff. But if you're just walking slow, there's easy ways to blow that off and say, well, you're getting older, stuff like that. But so we see a lot of people with both different types of disease processes, and the treatment can be different too, depending on what symptoms we're trying to take control of. Yeah, great question. Yeah. Okay. Yeah. Yeah. Yeah, so stem cell research is an interesting type of research they've been trying to do it for a while, and so basically, what a stem cell is a cell that could be made hopefully via different types of processes to take the function of a cell that has gone away or died off in your brain, and so there's thoughts about what if we can put some cells in someone's brain that make dopamine, for example. And then since we lose the substantia nigra, maybe we could put some cells in the brain that would help make dopamine. Or they've done a lot of work on this. The studies have not borne out to be beneficial as of yet. Doing studies in people with Parkinson's is difficult because it's difficult for all disease processes, but you have to be careful about things like a placebo effect. And so to do a good trial with Parkinson's disease, you have to, let's say we're going to do a surgery trial, which is what they're maybe doing with the stem cells. They do stem cells in a bunch of different ways. Sometimes they would drill a hole in your skull, put a needle down to a deep part of your brain and put in stem cells there. Well, it's really hard to do a trial like that with a blinded group of people, to have the surgery done and they do the trial, but you would know if you got it, right? Because you went into surgery and they drilled a hole and they injected cells there. So they actually do these things called sham trials where they have the people that got placebo to kind of go through the process but not get the actual administration of the stem cell. Sometimes they do a sham surgery where they make people, they talk like they've gone into the skull, but they haven't, and that's the only way to do that, to make sure that the people are really responding to the therapy and not just responding to the thought that they had the therapy. And so that's what makes some of these trials a little harder. Sometimes they do stem cell infusions kind of through an IV type of thing. These are things that are not proven to work at all. So if you wanted to Google right now, like stem cell therapy for Parkinson's disease, there's places in California where they'll do it to you. There's probably a few places in Denver. Definitely in Texas has a lot of places that'll do it that offer stem cell therapy for Parkinson's disease. These are typically run out of plastic surgeons' offices. And these are cash only type of things, and they're $15,000 to $25,000 to get stem cell therapy. And so I would certainly recommend avoiding it. There's nothing wrong participating in a clinical trial for stem cells, but doing stem cells at a pay out of pocket type of place is nothing I'd ever recommend. Since it's kind of the general rule with therapeutics that are more experimental, or someone trying to do a new therapy or trying to be part of a trial, you shouldn't pay for it. So that's like the marker that I pretty tell people to look at. Like, is this legitimate as a possible thing? Like, if the University of Utah is doing a clinical trial on stem cells, it's a clinical trial. So you're not, the clinical trial covers all of that stuff, and so you're not asked to pay $15,000 to get something either like, sometimes they do like fat pad biopsies, or they take fat tissue and they spin it down and they try to get these stem cells from that. And then they either, will kind of mist them up your nose or give them to you IV, those types of things. Those are nothing that I'd recommend, but you can find them out there for doing it with really nice looking websites. So, yeah. But so just I tell people to be aware of that. So yeah. But so hopefully there'll be some research that comes with that, but nothing has come out to be a definitive yet at using stem cells to treat Parkinson's. So they're still looking at that as a possibility. That's a great question. We don't really know. It probably becomes to be more on the rise the longer people live. So because people tend to get it as they get older. So if the population as a whole lives longer, there'll be more incidences of Parkinson's disease, and the number of people having Parkinson's disease in the population will go up. But is there some sort of environmental factor that we've put out there that makes more and more people get Parkinson's disease? We don't know. So I won't say no. I just say we don't have that information yet. So, but it's a great question. Yeah. So the most of the published data says over the age of 65, 1 to 2% of the population has Parkinson's disease. So it's fairly common. And so that means over 65, 1 to 2 out of 100 people would have Parkinson's disease. So it's not an uncommon disease. That's kind of the general rule. And so the older you get, like I said earlier, the more likely it is to occur. If you ask people from 20 to 30 age group, the incidence of Parkinson's disease is extremely low, but it does happen occasionally. I think I brought up Michael J. Fox again, just because he's a well-known public figure with Parkinson's, and I think he was had symptoms when he was 32, I believe, from reading his book. So yeah.
Does Parkinson's lead directly to death?
Yeah.
In January,
Uh-huh.
I'm from UA, the
Yeah.
guy that I knew many years through all my life. He had Parkinson's for years.
Uh-huh.
He died of liver cancer.
Right.
And this last June, another long time friend of mine, Parkinson's over many years, died in complications from a fall.
Right.
So
Yeah. So
Parkinson's
So yeah, great question. So most people die. What we say is most people die with Parkinson's disease, and some people can die kind of from some of the consequences of Parkinson's disease. But a lot of people with Parkinson's disease, and probably the majority of people with Parkinson's disease, tend to die from what everyone else does. So they die from heart attacks or strokes or cancers or whatever other people in the population die from. And that's an important point to bring up, because I always tell people that having a diagnosis of Parkinson's disease doesn't mean you can, ignore other aspects of your health. It doesn't mean you get to skip colonoscopies. It doesn't mean you don't have to take blood pressure medications or cholesterol medications. You still have to take care of yourself, even with the diagnosis of Parkinson's, because the other medical stuff that people experience as they go through life is just as deadly in Parkinson's as it is in anyone else. So yeah, people get cancers and people get heart attacks and strokes. Parkinson's can be more directly related to how people pass away when it becomes very advanced and it affects people's ability to swallow. And so if you get swallowing dysfunction from advanced Parkinson's disease, and food goes down the wrong pipe, so to speak, and leads to lots of pneumonias, that can be an issue where people pass away more directly related to Parkinson's. In general, the life expectancy of someone with Parkinson's disease is within a year of the general population. So Parkinson's does not cause any real significant reduction in life expectancy. It does really cause a lot more issues with mobility and getting around and increased risk of falls and things like that, but not necessarily a reduction in how long we'd expect someone to live. So the treatments are really focused on improving a lot of quality to people's lives that with Parkinson's disease. Yeah.
There's some reason
Uh-huh.
one day, or actually 1 hour,
Uh-huh.
occurs on a normal basis,
Uh-huh.
but then just for the hell of it, suddenly the next day you don't have any of those symptoms.
Yeah.
You feel really good and you think, all right, I'm free at last.
Right.
And then along comes a big disappointment, 20 minutes later.
Yeah,
It says, Stan, you fell out of the car again.
yeah. So that's there is a reason for it, certainly, and it has a lot to do with we're trying to achieve the perfect level of dopamine in your brain and trying to get that the perfect level of treatment. But because it's going to fluctuate with all sorts of things, it's hard to make that perfect. So to get the perfect level of medication, we have people take medication more frequently. But if they take the medication a little bit too frequently, they'll get too much dyskinesia and can fall from dyskinesia. Or if they're too far apart, it'll work and then it'll stop working before they're ready for their next dose. That's what that motor fluctuation stuff is that we're talking about. Or we call it on and off, where the drug works and they're on, they're doing well, and then they're off, the drug stopped working. So our goal of the therapy is to try to minimize the off time and try to maximize the on time. And that's why they're having kind of new forms of carbidopa, levodopa out on the market to try to really try to minimize that. But it's there's tricks to that too. Sometimes if the carbidopa, levodopa level or the dopamine level in the brain gets too high, people can hallucinate or they can have their blood pressure drop low and they pass out when they stand up. These are all things that we have to work on to optimize therapy. And so, sometimes it has, I think a lot of how well someone sleeps at night makes a difference. So if someone gets, for some reason, a good night's sleep, the next day they're great. If they get a bad night's sleep, the next day they're having a really hard time. And so those are things that we always try to look at too. I think, sleep in Parkinson's disease is a thing that we try to improve, but it's not an easy thing to fix. So, great question. So to answer the question simply, there's lots of reasons why. One day you're doing great, and then the next day or the next hour you're not doing as well. And what we try to do when you're at a doctor's is try to figure out what situation for the hours of the day before you're feeling great were we adhering to, and then what thing happened consistently when you're not doing well, and we try to optimize the thing that you were doing for the good time when you felt on and you felt like you're doing well. So it's going to be variable though. So great question. Yeah. Well, good.
In
Yeah.
the progression of the disease, we have a lot of friends who have Parkinson's. Say more about the variation.
The progression.
Yeah.
Yeah. So that's a great question. So the question is about what type of variations do we see with the progression of Parkinson's disease, and it's highly variable. And we don't know why it's highly variable. Some people will progress aggressively, meaning that they just seem to deteriorate over every 6 months. They have more difficulty with mobility or gait or falls. Other people progress much slower. We know that there's an association with activity. So we know that the more healthy someone is, the more active they are, the more exercises they do, the slower they tend as a group to progress slower and to be more mobile as time goes on. And for people that tend to be more sedentary, they tend to progress faster. And I say that as a tendency because I don't want someone to feel like if they're progressing faster, they just needed to work out more. It is not always directly related to that. It's just there's an association there. So we know that the more exercise someone does, the more mobile they are. As the years go on, they just tend to do better, and so that's something to keep in mind. Other people just have a type of Parkinson's that is more aggressive and progresses quicker and causes more difficulty with gait or balance. Some people have more difficulty as the disease progresses with cognition, more difficulty with dementia, hallucinations. Other people don't really get a lot of that. And it's just that we talked about this kind of different flavors of the disease process as they progress. So we treat everyone individually to try to do that. But we know the consistent thing is mobility and exercise. And then I think like stuff like the Rock Steady boxing groups and stuff like that, these kind of communities of people that exercise together are really excellent things to add. With exercise in Parkinson's disease, there's never been a negative trial. So there's never been someone says this exercise did not work. So I always tell people the only exercise you shouldn't do is the one that you hurt yourself doing. So if there's a exercise that would cause you to get hurt, don't do that. But if there's an exercise, but every other exercise is fair game, as long as you're not hurting yourself. So if I say go to rock steady boxing and you say, well, I hate boxing, well, then that's okay. Then you could do dance classes if you like that better, or you can do Tai Chi, you can do yoga, you can do Pilates, you can do whatever type of exercise you want to do. You could work out at a gym by yourself. You could work at a gym with a personal trainer. You could walk. You could walk on a treadmill. You could use an exercise bike. There's no bad exercise. There's probably exercises that are better than other ones. So exercises that you have to think about what you're doing while you do it are probably better. So exercises that not only engage your body, but also your mind tend to be better, I think. That's not, I think, been definitively proven. That's an opinion. I think that those exercises are better. So let's say like dancing, I don't know I would be a terrible dancer, but so if I had to dance, I'd have to really think about it, right? I'd have to think, okay, left foot, right foot, don't step on my partner's foot, all that other stuff. Like that'd be hard for me, but that would be better for me probably because I have to really think about it. And so I'm actively engaging my mind and my body together. Or if I was boxing, you have to think left, left, right, uppercut. So, you have to think about that type of stuff. Where if you just walk on a treadmill, you could read a book, you could watch TV, you could, while you do it. And not that that's bad, there's nothing wrong with walking on a treadmill, but it might be better to do the other one. So the best exercise to do is the one you're willing to do. And then if you say, well, I want to do the best exercise for Parkinson's, it's probably one of the ones that's more mentally engaging. But don't think like if you can't do one of those, that you shouldn't do anything. So anything's better than nothing. So swimming or anything like that, it's all great stuff. So yeah. Oh, I've always found the disease fascinating. My father's a neurologist, and so that was a big influence. And then there's a movie called based off a book called Awakenings by Oliver Sacks, and he's passed away, but he was a very famous neurologist who wrote some really interesting books about different neurologic diseases. And so he wrote this book called Awakenings not about Parkinson's specifically, but it's about people who had something called von Ichmel's encephalitis. So sometime after, there was the 1918 Spanish flu epidemic, that hit the United States and all over the world, and millions of people passed away from the Spanish flu. A couple years after the Spanish flu, there was another flu epidemic that came through that wasn't as severe, but was associated more with encephalitis or brain swelling or infection. And some of the people who got this brain encephalitis, this bad fever, headaches, confusion, they got better, but then they developed a Parkinsonism, a Parkinson's-like disorder. And so this movie, because I watched it as a kid, I wasn't reading Oliver Sacks's books or anything like that, but I watched the movie, and it has Robin Williams is in it, Robert De Niro's in it. Robert De Niro plays the patient who has Leonard, I think is his name, who had the encephalitis, and these people were frozen. It was like they had advanced Parkinson's disease. They couldn't move. They were rigid, and they would sit in a chair, and they were called waxy, which means that you could mold them. You could move them around, but they wouldn't move a lot. And then Oliver Sacks tried levodopa in these patients. This was pre-carbidopa levodopa. This was just when there was levodopa by itself. And levodopa it's called, we give it to people in carbidopa levodopa called Sinemet, which is Latin for no vomiting, because if you just give people lots of levodopa, they'll get sick and kind of throw up. But he was able to give people low doses of levodopa and build up the high doses of levodopa, and then they woke up. So they were treated for this Parkinsonism, and they woke up and could move. And then there was this big kind of awakening of the patients. And so they found a lot of patients. This is in the 50s, where they found a lot of patients who had, when the 1920s, early 1920s, been exposed to this, and they were in nursing homes now. They gave them levodopa. They could move better, and they could talk, and they would wake up and do the things that they wanted to do. And then, unfortunately, they ended up getting dyskinesia, these extra movements that people with Parkinson's can get. And that dyskinesia limited their treatment and their treatment with the medicine. So we don't see von Ichmel's encephalitis like that really anymore. I've seen a case or two in Africa, but nothing that we see here very commonly, because we haven't had a big pandemic of that type of disease. But that movie was probably what interested me. Long story, sorry, but that movie is what kind of really interested me in movement disorders as a field. This idea we could really affect people's ability to move and kind of treat their symptoms well. And then with other things that have advanced with people using deep brain stimulator surgery, for example, can be a really amazing thing. It's not a cure for Parkinson's or a cure for tremor, but it can help really optimize the treatment and help people function as best as possible. So those things are what kind of interested me in it the most. But yeah, that's where I got interested into it. So watching that movie with my dad, and he would explain, and it wasn't, as a kid I was nowhere smart enough to really understand what was going on with the drugs in the movie, but having my dad there to tell me, how this is working, what they were doing, was really kind of influential. So yeah. But it's a great movie if you want to go watch it. Awaken, if you guys have seen it, yeah, it's a great movie. Robert De Niro is really good in it, and so is Robin Williams. Yeah, there's a lot of clinical trials going on right now with different variations of different medications or drugs. There's nothing that I could say is on the cusp of being necessarily super groundbreaking that I know of. And that caveat that I know of is something that other people may say differently. A lot of people more involved in research tend to think that there's more of a thing right around the corner that's going to be groundbreaking, but we don't have anything like that yet. Probably the stuff that we've seen in the news more recently has been, there's new treatments for Alzheimer's disease that are out, and these are called anti-amyloid therapies. And so we know that people with Alzheimer's disease get a buildup of amyloid in their brain, and so they have these drugs now that are designed to attack the amyloid or to remove the amyloid more specifically, and that may help with the treatment of Alzheimer's disease. They haven't been profoundly robust at treating the disease process. It may help shut the disease process down. We're still kind of waiting for that information to come out. The point being that we know that in Parkinson's disease or Parkinson's disease-like processes, there's a different protein that builds up in people's brains. And so they're looking at doing the same type of drugs to treat Parkinson's disease to see if we could remove alpha-synuclein from someone's brain, or some other proteins that are more associated with Parkinson's. And these trials thus far have not been as robust as the Alzheimer's trials have been. In that being said, the Alzheimer's trials are not really robust in their response, meaning they have some high risk to the patients with using the drugs, and people are getting some clinical response, but it's hard to say how much or how drastic it's going to be. So one other thing that came into the news is like a Ozempic-like medication. Ozempic is a very popular thing to talk about because it's a weight loss drug that's out on the market that you can give yourself an injection to, and a lot of celebrities use it. So people talk about it a lot. They've found that there might be some benefit to people with Parkinson's disease with this type of drug, and they don't know why. There's some theories as to why, but nothing's been proven. But it seems like Ozempic may be associated with some improvement in Parkinson's disease, but we don't know. So Ozempic. Oh, I'm a terrible speller. O-Z-Y. I'd have to use my phone to tell you how you'd spell it. Okay. I want to say the commercial. I think they like the commercial, which was like Ozempic or something like that. Okay, let me see. Okay. Let me see here. They'll edit this out of the video. Okay, so Ozempic. Yeah. But so it's a drug in the class of Ozempic that's been shown to be kind of possibly associated with some Parkinson's benefit. So I'm definitely not saying to go to your doctor and say, Dr. Kareus said to put me on Ozempic to treat my Parkinson's disease. So I'm not saying that at all, but I'm saying that's a news story that I was looking at. Before I ever do a talk, I kind of say like, I look through like a Google and try to figure out what are the news stories about Parkinson's that people may be seeing. There's a story all the time about this drug is going to be the next big thing, or this drug is going to be the next big thing, and we always hope that that's the case. But I've seen throughout the years, there's sometimes a lot of hope that's brought up, and then it kind of fizzles out as the drug tends not to work. And so there's, I definitely don't tell anyone to delay using one therapy because they heard that this drug is going to come out in 10 years or 5 years or 2 years, and it's going to be so much better than what we have now. I've never seen that happen. One of one of the best doctors I used to work with as a med student was a movement disorder specialist at University of Arkansas, and he was a great guy, and he was really great clinician. But he used to tell people that he thought, in 10 years we'll have a cure. Is what he would tell his patients, and this would have been in 2003, and so we didn't, and so now it's been double that time. It's been 20 years, and we still don't have a cure for Parkinson's. And so that's not to say that anyone's stopping trying or people aren't doing active research about it. It's just that I do temper people's expectations about reading kind of popular literature about the new treatment for Parkinson's. It's just that we everyone hopes it's going to be the case, but I always carry a degree of skepticism when I hear about the newest drug that's going to totally reverse things. But if it does happen, I'll certainly be the first one to prescribe it to everybody who wants it, once it's been shown to work, but we just don't have that yet. But so when I talked earlier about like skin biopsies or looking at the GI system for really early diagnosis of Parkinson's, that's when that would really be important. If we had a drug that would say like shut the disease process down super early, then it would be really important to diagnose people super early. The danger that we have now, if I try to diagnose someone really early or with minimal symptoms, is that I could be wrong, and I've told someone who doesn't have Parkinson's disease that they have Parkinson's disease, and we don't want to do that. We want to be pretty sure about what we're treating, So, yeah. Great. Yeah. So that's a great question. The question is about cognitive problems, hallucinations associated with Parkinson's disease. And so it is not uncommon for people with Parkinson's, as it becomes more advanced and as they age, to get a dementia, to get cognitive issues, short-term memory loss, confusion, and then more, not solely unique to Parkinson's, but more associated with Parkinson's disease dementia and Lewy body dementia is the hallucinations. Typically, hallucinations start out as something that the person who has them can figure out that they're not real. So usually it's like, hey, there's a rabbit over there, or there's birds in the room, or there's a mouse over there, but then the person looks, they don't see it, they can okay, there's not a rabbit in the house. I thought there was, or there's kids in the back of the room, but then they blink their eyes, they look again, okay, there's not kids in the back of the room, or there's someone out in the field. Is a common one I get. When I look outside and there's a person out there. But then they rationalize there's not a person out there. And so those hallucinations and the ability for the person to get some insight to the fact that they're not there is fairly common. As the disease advances and the hallucinations can get worse, then sometimes the hallucinations are harder to figure out if they're real or not. And sometimes the hallucinations can become threatening. And if the hallucinations become threatening, then it's a bigger deal to treat, or you want to kind of take command of those or treat those. Because you've certainly heard of many people, not many, but some cases where the hallucinations are so bad that people want to shoot at them, or they cause people to get in their car and drive away, or move, all that type of stuff. And we want to avoid that type of thing. So when I have someone who starts to have some hallucinations, the first thing I look at are their medications. I say, okay, am I part of the problem? Am I giving someone medications that would be associated with them hallucinating? So typically the drug amantadine, which is a drug that we use to help with dyskinesia, that can cause older people to hallucinate. And so, as well as a drug called an anticholinergic, like Artane, which is another drug we use for tremor, if they're on that, they have to get off that. Then if they're on some of the dopamine agonists, the Mirapex, the Requip, the Nupro, those can cause more hallucinations. So we kind of get rid of those. And if the hallucinations persist after getting rid of the medications that could cause it, we use some drugs to help limit the hallucinations. We use off-label a drug called Seroquel or quetiapine, and there's a drug called Nuplazid, which is similar to that, which helps with some of the hallucinations. Yeah, hallucinations can occur without dementia, but they're very highly associated with dementia. Okay. Yeah. So with the inhibitors that we use for the dementia would be a different class of medications called acetylcholinesterase inhibitors. And so that's another point. There's a group of drugs that we use to treat dementia that are called acetylcholinesterase inhibitors, and this would be mainly a drug called Aricept or donepezil, and that's a drug that we use to treat people who begin to hallucinate as well too. No, so the anti-amyloid drugs aren't really. We don't know if they're associated with any reduction in hallucinations. They're really associated with the reduction of amyloid in people's brains. Now, but that's an argument is then, does that reduction in amyloid in people's brains, how much of a clinical effect does that have in somebody? So that's really for Alzheimer's specifically. They don't. There's different diseases that have the word amyloid in it. So there is systemic amyloidosis or stuff like that, or in different types of things that build up in people. But those are a little bit different disease processes. Yeah. Yeah. No, there's not a good study with that, but I don't have a problem with people taking lion's mane mushroom or anything like that. But it is, yeah. I mean, I have a supplement that has some of that in it, but I don't know of how much it works. Yeah, so there's not a study with psilocybin that I'm aware of for cognition. Most of the psilocybin studies are more for PTSD and depression, and then for the cannabinoid stuff, there's still, since it's still federally illegal, and same with the other psilocybin stuff, it's still restricted in its use for clinical trials. So I don't hold out a lot of hope necessarily for a lot of big benefit from cannabis related products. I think that for CBD by itself, it helps people sleep a lot. I've never had anyone, I wish it was not true. I've had one or two people probably tell me that CBD has been helpful for their tremor, but the vast majority of people tell me that it's not that helpful for their tremor. And for CBD, THC, just kind of more standard marijuana types of products, I've never heard anyone say that it really helps that much. I generally, if you're having cognitive issues, I do not really ever recommend anyone take a THC product, because it's, I've always told people I've never met anyone who did a lot of marijuana that seemed to me to be smarter. And so if you're having cognitive issues, using regular marijuana is probably not a good idea. Or if you use a small amount to help you sleep, I don't have a problem with that. But if you say, hey, I've never done this drug before, but I've heard that it might help me with cognition, I'm going to try to use some of it or eat oral, like an edible. I think that's a recipe for problems. And I've seen more than one or two people in the hospital for similar, not for the person trying to treat it, but just overdosing on that type of edible product. Yeah. Yeah. So, but it's interesting to see if that would work, but we don't know. Usually they start small. I mean, usually, like I said, they're usually peripheral side of the vision, like a mouse or an animal or a kid. And like I said, usually the person who's having them has fairly good recognition that they're not real. And this they figure it out. But then as the years go on, they can become much more vivid or threatening. And that's when we use different medications to treat it. Yeah. Yeah, it's a great question. So the question is, anything that you've done for people with irrational behavior or bad judgment? So the first thing we do when I start to see that occur in people is I start to, once again, make sure that we're not part of the problem. So I look at their medications and say, are the medications that we're using here making people more impulsive, more irrational? And so that would be the same thing with hallucinations, removing things like amantadine, trihexyphenidyl, the dopamine agonist. The dopamine agonist can be associated more with obsessive compulsive irrational behavior, so getting rid of the dopamine agonists. Sometimes we even have to reduce the carbidopa levodopa if that's also contributing to it. But that's kind of the last drug that we tend to reduce, although if they're on really high doses, we may reduce that earlier. So it depends on the patient. And then if that's the case, then we have to do more traditional things to do. So we try some medications like Seroquel. or other drugs, which is the quetiapine drug. Sometimes we have to refer people to psychiatry or geriatric psychiatry to use more powerful medications, like clozaril, for example, if someone's having the irrational behavior move to psychosis. And then, doing things like, making sure people aren't driving, getting designated power of attorney, all that type of stuff, which is something that we have to do sometimes. It's not a common thing to happen. So, and it certainly doesn't happen in everybody with Parkinson's disease or anything like that. It doesn't probably happen to the majority of people with Parkinson's that they progress down to a road of psychosis or anything like that. But for a minority of people with Parkinson's, can have more of this neuropsychiatric problem, and it's a very difficult thing for families and for the person with the disease process to treat. So yeah, that's all we do. So we our medications, and then we add medications if our medications aren't part of the issue, and then we look for help from our colleagues in psychiatry if we need it. Yeah. Mhm. Yeah, it's a great question. I mean, the question is, if it's a brain disorder, why doesn't it show up in an MRI scan? It's because the MRI scans are not sensitive enough to see the small area of the brain and to see its function. So that's why a DAT scan, which is looking at like the level of dopamine, like the dopamine transmission, that's why it'll show up to be positive. And a DAT scan is a type of CT scan, but an MRI scan can't see the specific pathology that's taking place. Now, if they use these things like high Tesla magnets, which is really powerful magnets, in some studies, they can show a atrophy of different parts of the brain that are associated with Parkinson's disease, but they can't show it consistently enough to make a diagnosis. So if I read an MRI scan report that said, atrophy of, substantia nigra seen or demineralization of the substantia nigra consistent with Parkinson's disease, I really wouldn't know what I've seen that before, but it's not really anything that you can really see. And it just has to do with the type of pathology we're looking at. Yeah, there's other, yeah. Right. Well, so yeah, I mean, the most powerful MRI scans that we use typically clinically are what's called 3 Tesla MRI scans. But if you use like a 7 Tesla magnet, which they do in research, or 9 Tesla, these super powerful magnets, which actually start to cause some physiologic changes in people because the magnet's so powerful. They actually even can be associated with some behavioral changes in people. But anyways, they can probably see some of the pathology that you could see in Parkinson's. But we have other ways to do it now with DAT scans and most importantly, the clinical exam in people. Yeah. Yeah. What?
Right now.
Mhm. 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 Yeah. So, okay. All right. All right. So yeah, we're gonna do a fire alarm here in a second. Okay. Okay, so it's a great question. So, is it inevitable that people will get tremor or anything? There's really cognitive issues. It's not, and so really nothing is inevitable with Parkinson's, and because everyone is so different in their progression, lots of people have had the disease for years and years and have had no appreciable cognitive issues in that I see, and a lot of people have never had tremor, and a lot of people have severe tremor, but they don't ever get super rigid. They have some rigidity, but they don't get really rigid. And so there's nothing that's really inevitable with the disease process. I think that if everyone lived to be like 130, probably something would come up to be the inevitable with this type of stuff. But since we don't live that long as people, people sometimes don't get all the features associated with the disease process. A great question.
Other neurological diseases.
Mhm.
Like
Mhm. Yeah, I mentioned one, and so this gets to be kind of some mouthfuls of different disease names, but So I mentioned PSP, or progressive supranuclear palsy. There's a variant of something called multiple system atrophy, which are diseases that kind of look like Parkinson's disease sometimes initially. There's a disease called cortical basal ganglion degeneration, which looks like a very asymmetric Parkinson's. Now, regular Parkinson's is asymmetric, but this is drastically asymmetric. And then there's Lewy body dementia that can look like Parkinson's, and vascular Parkinson's, which looks like Parkinson's. Those are kind of the main ones that look like Parkinson's. There's a few more esoteric ones, like, for example, juvenile onset Huntington's disease looks like Parkinson's in young people. But these are, but those are the main ones that we're looking at that are that we see clinically a lot of. There's a form of spinocerebellar ataxia that can look like Parkinson's. SCA2 kind of does that. But anyways, so there are some that look like, and that's why you want to see a neurologist to try to pin that down and to make sure that that's the diagnosis we're treating, that we're treating the right diagnosis. And they all have different features. So multiple system atrophy is associated with much more autonomic dysfunction, so a lot more difficulty with maintaining an appropriate blood pressure and stuff like that. So good. Mhm. Yeah, they certainly are, and there's a lot of resources that go through the NIH, and so the government-funded resources. There's a lot of resources through private industry, through pharmaceutical companies. They're also trying to research different interventions, and so there's a lot of research that's taking place to try to find a treatment, a more appropriate treatment, a more appropriate cure for Parkinson's. And I think that really the cure is kind of a hard thing to talk about because I don't know what that would really look like, but a treatment or a way of stopping the disease progress is what we're really looking at as far as the future. But then the other future is more in therapeutics, which is looking at ways to optimize people's function with these that have Parkinson's and treat their symptoms the best. But yeah, there's a lot of money being put towards that, and it's just we'll see how far we can get with all that research. We hope so. I mean, I think like things like the Michael J. Fox Foundation have been huge proponents of advancing research. Partners in industry have been huge proponents of advancing research too. So, yeah. So there's a lot of effort being spent to try to find ways to optimize people's function with Parkinson's. But it's for anyone who has Parkinson's disease, I certainly understand the feeling that it's not enough. And we should do more, or we wish there was more that could be done, but that's where we are with that right now. Yeah, so I think that there are separate kind of issues, and the fact that certain Parkinson's disease can lead to disability, and so if you are disabled from Parkinson's disease, you can get disability like anyone else can. Uh-huh. Uh-huh. Yeah, that's true for any disease process. So the comment is about how long it takes to get approved for disability from Parkinson's disease, and that's I have a lot of patients that get disability for Parkinson's disease. It depends on how old they are. Are you if you're already retired, getting disability is different, I believe, and so and I think it's a process to work through Social Security disability to get it. So they look at your doctor's documentation about what your limitations are, and that usually dictates how people get disability. Unfortunately, it's not like a prescription from me. So if I wrote on a prescription pad, like you can get disability, you can't like take that to Social Security and they say, look, you wrote this prescription, I can get it. It's a process where you have there's forms to fill out, there's like external review of your medical records and stuff like that. So it's a slow process, but certainly one that if you need it, it's certainly justified to get. I mean, and for veterans, there's different things too. I think Parkinson's disease is listed as a disease for things like Agent Orange exposure, Camp Lejeune water toxicity, and maybe some other stuff that's more military exposure history. comes up. So, and if you have Parkinson's disease, it affects the amount of service connection coverage you get from the VA if you're a veteran. So, great questions. Yeah. Well, great. Yeah. SDF? I don't believe I have. Uh-huh. 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 Yeah. I haven't heard about any clinical trials being positive for something like that. Certainly sounds like it would be something that's being investigated though. Yeah. I haven't heard of one specifically. Well, great. Well, good. Well, I think they want us out of the room, I think at noonish, I think. So any other questions? If not, we'll just say we'll close it there. But it's really great to talk with you guys, and it's always great to speak with people. So hope you guys have a great day and a good weekend. All right. Yeah, sure.